Welcome to Voices in Health and Wellness. This is the podcast where we sit down with the practitioners, founders and change makers redefining care in today's ever-evolving landscape. I'm your host, Dr. Andrew Greenland. Today's guest is someone who is truly making waves in neurodevelopmental space, Dr. Antonietta Pirello, a consultant clinical psychologist and founder of the Spectrum Clinic. Based in the UK, Antonietta specialises in adult ADHD assessments that put people first. She's passionate about delivering gold standard diagnostic work, breaking down stereotypes, and helping healthcare professionals better understand ADHD. Antonietta, welcome to the show. Thank you so much for joining us today.
Hi, Andrew. Thank you for inviting me.
So perhaps you could start at the top, perhaps give us a little bit of background as to how you got into this space and what your work is all about.
Right. So, I'm a clinical psychologist, founder of the Spectrum Clinic and ADHD Match. So I primarily do autism and ADHD assessments. I offer training for clinicians. So I train them to deliver ADHD assessments and support them with that journey of establishing their practice. But I didn't quite start straight away like that. So I qualified in Italy as a clinical psychologist, so Doctor of Psychology in 2012. And my specialty has always been developmental psychologist and psychopathology. So conditions, neurodevelopmental conditions such as autism, ADHD, specific learning difficulties, and so on, have been part of my core study. But I started working with children to begin with. When I then moved to the UK, children and adolescents, when I moved to the UK, I started having a mixed bag of experience also with adults. And especially, on the more severe end of the spectrum or neurodevelopmental conditions. And something changed inside me that made me think, okay, something is not quite right, because often these people sit in between services. There are a lot of gaps, and working through camps for a number of years, then leading another service for transforming care pathways, it became apparent that there was a different way, that surely there must be a different way for us to support neurodivergent people, not just with assessments. So I think the big shift for me has been from a purely medical model to embracing at least key elements of the neurodiversity paradigm. So it's been a journey. A fascinating journey. I have developed more and more a passion for ADHD, and that's where I've specialised, especially in the last few years in private practice.
Thank you. Always good to hear about the background and inspiration to do what you do. There's a lot of noise in the media about neurodivergence, the diagnoses, the number of diagnoses going up. What's your take on this, and how do you kind of explain what we're hearing in the media to people that you see?
Oh, it's a constant battle. It's something I discuss straight away in my training as well, because everybody has experience of, especially in regard to ADHD. So with autism, we saw this happening about 10, 15 years ago, when, autism seemed to be in fashion, seemed to be a trend of the moment. And there was an increase in referrals, an increase in the people children that we were assessing. And the same movement is happening with ADHD, and social media is playing even more of a crucial role. There are a lot of the younger generations, they jump on TikTok or Instagram, and there's a lot of video content and more awareness around these conditions. So I think part of it is people becoming more aware about their own experience, and therefore showing up to their GP for assessment, right? Requesting an assessment, and eventually to services. Another side of it is there is a bit of quite a bit of misinformation around. And actually, the data tells us that we're not overdiagnosing although it still remains a concern, it's still something that we need to monitor because we need to be accurate, right? So we need to follow the guidelines. We need to follow the standard procedures for these assessments ethically. But actually what we know is the opposite, that in regards to ADHD, because that's where the clue is at the moment, is underdiagnosed, especially in women, or the inattentive presentation. We're coming to understand it better, to recognize it better, and therefore there will be an increase in, generally speaking, rates of diagnosis. But these are people who have been missed, 20 years ago, 30 years ago, when also the DSM criteria, right? So 3 and 4th edition of the DSM were different and less inclusive than what they are now in the DSM-5. So it's a combination of factors. On one hand, you have more awareness through media, social media, even when the media is negative about ADHD. And on the other hand, you have, diagnostic criteria that are permitting the overlap with autism spectrum disorder, for example, which wasn't possible before 2013. The age of onset, has changed, so it's been raised. There are things that have changed that allow us to diagnose. So up till 2013, we couldn't diagnose someone with ADHD if they had already a diagnosis of autism. And considering that the overlapping, so the comorbidity is the norm rather than the occasional occurrence, then we missed a large part of the population. So that in itself explains a lot of the why the diagnostic rates will go up. They are going up. That's what we see anyway. That's what we know is happening. Although the numbers and figures will be, revealed at the end. We will see what they actually are.
Thank you. So you talked about this sort of raising awareness over recent years and how the clients are approaching this or viewing this. But what about other clinicians, both in and outside of your space? How are they approaching all of this? Is there an ignorance outside of your particular niche about this condition as well?
Yeah, the word that pops to mind is ignorance and scepticism. Because if you think about it, even someone like me who started training in clinical psychology in 2000, right, it's been 25 years, if I remained stuck to that kind of training, I would have a completely different view of neurodevelopmental conditions, ADHD. But it's not just a matter of age, it's a matter of how the culture and the systems in the services that provide this kind of assessments. So I think we're slowly reaching clinicians, but it's not unusual that clinicians who come to my training, they express their concern that perhaps people coming to the attention of services may do so because it's trendy, because there is a secondary gain of some sort. And they don't seem to, not everybody seems to grasp the idea of camouflaging so that someone can be inattentive and you don't notice it. Also for ADHD, that someone can be struggling in their life, but in that 1 hour, 2 hours that you spend with them, you may not see it. So I think there is a cultural shift that needs to happen in service provisions, and a retraining of staff to embrace what we know from research. We don't have to embrace any philosophy without verifying it, but there are some key elements that we know from research, and we go with those ones.
Thank you. So what does your typical day look like at the moment? And I presume there is no such thing as a typical day, but how does it kind of fit together with the kind of clinical aspects, the administrative aspects, the aspects of running a business? How does it all look?
Well, busy. It takes a lot of organization and trying to keep boundaries, learning to delegate as much as possible, and asking for help. I try to practice what I preach. So I have a business coach now who keeps me on track with everything. So I will have clinic days when I typically do 2 assessments, one in the morning and one in the afternoon. I may have other days when I do an assessment and perhaps I have a couple of patients. And the rest is about, I'm very passionate about delivering training and creating resources to help clinicians. So I will spend it in my ADHD match community. I will answer questions. I offer a lot of supervision. So Monday afternoons tend to be for supervising clinicians. It's hard to keep, that rhythm. But so it's my day is varied. What I've learned to do is to start a bit later, because it works well with childcare and other commitments, and perhaps finish a bit later, so that it suits me best.
Thank you. I don't know how demand is at the moment. I'm guessing it's huge. And obviously with the increased awareness and self-diagnosis, how is demand being met for the assessments? Not just in your practice, but more generally. Is there a massive backlog with all these people waiting to get some kind of clarity over whether they have this diagnosis? Where do you see demand and supply at the moment?
There is a lot of backlog. Unfortunately, there's always been in the NHS. I mean, with the introduction of right to choose, which is a pathway, a very useful pathway where people who think they may have ADHD or their children may have ADHD can choose a private provider that has a contract, with the NHS to do their assessment, and they would not pay the fee, so the NHS would cover. And this scheme has been introduced to, to try and reduce the waiting lists. And in some areas, they can go up to 7-8 years. We've seen clients privately who had been waiting for a very minimum of 4 or 5 years. People don't go into a private assessment because they have money to splurge, generally, because they're expensive assessments. They require a lot of time, both admin and organizational time, skills. So that's the very minimum. So they usually go to a private clinic when they don't have an alternative, or they have been through services and these were unhelpful or perceived to be unhelpful, such as a referral wasn't initiated, or they didn't meet the screener's threshold, and so on. But the right to choose is a very good scheme, and that's how the NHS is tackling the matter. The problem of right to choose is that only bigger companies get to go on the right to choose because they have the infrastructure, they have the money to invest, they have more the financial power to adhere to all the regulations, all the things that are necessary. It's not impossible for small practices, but there are compromises to be made.
Got it. So with this massive demand-supply mismatch, is this changing the way that clinicians are engaging with the patients that they see, or even how they're trained? Because obviously you have a foot in both camps. You're seeing the patients, but you're also helping to train others. How are you kind of taking on board this massive demand in supply and demand in the work that you do?
Well, I think there are a lot of more independent practitioners who are offering ADHD assessments at the moment. So I think the demand is spread across a lot of providers. Clinicians are starting to shift their mindset and the way they see neurodivergence or neurodevelopmental conditions, to support people not just as a problem, not just as something that creates distress in some areas or impairment in other areas, but it's something that also brings strengths. So the shift is around supporting people and meeting people where they are, supporting them with what they like, with the things that, with their ambitions, their aspirations. Again, trying to accommodate or find solutions for their weaknesses and put more value and emphasis on the strengths. A lot of clinicians started adopting, a neuroaffirmative way of dealing with their patients, which is exactly that, not just looking at neurodivergence as a disorder, but as something to be valued, and more it goes back to identity. So from a medical condition to something that is part of a person, it's a different way of seeing the world. Is a different way of interacting with the world, and it is as valid as the rest of the people out there. So there is definitely a shift towards that perspective.
Thank you. We're going to talk a little bit about stereotypes, because you must see an awful lot of stereotypes around ADHD. What do you think are the most damaging or persistent myths that you're still seeing in 2025?
Unfortunately, is towards girls, ADHD girls, that, the girl who is complying and doing well in school, or apparently, not causing any problems, cannot possibly have ADHD or be ADHD. That is the main problem that we have. And understandably, from a teacher's perspective, if you have a large classroom and you're trying to manage, the lesson, but also different types of learning styles in children and behavior and so on, the girl who is, also boys can be inattentive, but predominantly girls tend to be at a young age, then the girl doesn't cause problems who may be daydreaming for the whole lesson gets missed.
Wow.
That is a big one still now.
Interesting. There's a kind of a gender stereotype here with this. That's really fascinating. What about other health professionals? Are there any stereotypes or misconceptions amongst health professionals who you'd expect to know a little bit better?
The same, pretty much the same. But also, I think the misconception is that they expect to be able to see, ADHD. And especially with the inattentive presentation, it might not be so. They expect to be able to record behaviours and fill in checklists. And what it truly matters actually is the experience of that person. So if you talk to them and you ask them to describe their day, a typical day, as you just did with me, what does it look like? Perhaps starting, from the morning and getting up, and how they manage school, how they manage when they're dreaming, what do they do? Is there anyone supporting them, and so on, that until, the day ends, and how often that occurs, right? Is it just a day off, or is it a one-off, or is it a daily occurrence? Then you get to really grasp the not just their experiences, but you find the things you're looking for, which we're thinking about symptoms and criteria, right? But they cannot be separated from the stories. And if we go in and ask direct questions, I don't know, do you make careless mistakes on a daily basis? People may not be aware that they're doing that. Actually, we know that adolescent boys especially tend to underreport. We know that teachers may not be able to pick up on subtle cues. And as clinicians, if you are not trained into doing some behavioral analysis, for example, you may miss micro expressions, you may misinterpret what's happening in the session. But it is possible to observe it, not in the typical way. You don't always see a woman or a girl, standing up and having to fidget and having to move, or being verbally hyperactive, so talking a lot, which, the hyperactivity symptoms are the make clinicians feel safe because they have something that they have observed. While around inattention, they need to become subtler and subtler. So that's what they tend to bring in supervision, to say, can I trust this patient when they tell me that? Like, well, if you gather enough examples, if you gather enough, that's the evidence, isn't it? It's the stories, is what they tell you. Okay, examples for each symptom. Then yes, you're more likely to be able to trust what they say. And why should you not? Is there a reason not to trust them? So that's the other question that I ask. Is there a reason not to trust what they're telling you? What is it about? Is it a lack of confidence in your skills? Is it something about that client or patient that is that feels a bit off, or feels a bit inconsistent or incoherent, and so on?
Thank you. So what's working really well for you in the clinic right now, and what are you most proud of in terms of how you've structured your practice?
It is my team. We are a small team, and like-minded practitioners. We have a couple of clinical psychologists. One of them is clinical and educational psychologist, a speech and language therapist. We have a pharmacist prescriber, just about to get another one, and working on improving the practice always. But those are, these people really share some deep values. So if they have to spend more time with a client or a patient, they wouldn't say, oh no, the 2 hours is gone, or this is my fee, or they would always go the extra mile to follow up, to find additional information, even if it means, reaching out to external sources of information, a parent, a teacher, a partner, and so on. They always want the best outcome for the clients. And with that in mind, they're really... we work in an MDT, so multidisciplinary team. So when we meet after an assessment, the aim is, how can we help this person? And we give it some proper thought. So it's not just, copy and paste recommendations because we're in a rush and the next person is waiting. No, that doesn't work like that. Another thing I'm really proud of is how the clinic has evolved, because we try to be as inclusive as possible. So we take the feedback from our clients at heart. After each session, after each assessment, we always ask, what could we do better? So we're really open to suggestions, and we modified our practice to be that inclusive. Examples may be, staggering the forms that we send so people are not overwhelmed, asking if they need someone to be on the phone and help them complete a questionnaire because perhaps they're dyslexic. And as I've already mentioned, neurodivergence and neurodivergence goes together. So we see high comorbidity rates. But not just that, all of those things, I think they make us feel more like I wouldn't say a family, but a very caring team, very caring.
Amazing. And on the contrast, is there anything that's frustrating, more difficult than expected, or bottlenecks or challenges that you are had to overcome in your work?
quite a few challenges. The main challenges that we face are after ADHD assessments, and is with liaising with other services, especially NHS services, to get some support. There is no support, barely any support out there. So whoever comes for an assessment then will have to typically either go privately for therapy, coaching, medication, or rely on charities, support groups. Some of them, I think that they're popping up more and more around the country, and they do an amazing job, really, very often without getting paid, because they have lived experience of ADHD, or they have a family member, a child with ADHD, so they volunteer their time to help others. The biggest frustration is with medication, ADHD medication, because services are pulling away from shared care agreements, and from not everybody, not every GP practice or service would recognize an independent assessment, right? A private assessment. Some do. So when I started, we would typically refer back to the GP with a thorough report. And by thorough, I mean at least 20-25 pages of evidencing how they meet the criteria and excluding other things that could potentially explain the symptoms or the presentation. What we were seeing was GPs very keen to review. We received a very positive feedback, and they would then refer on to community mental health services, right, for a psychiatrist review. The problem is that the waiting list is as long as an assessment's waiting list.
Got it.
And that's the best case scenario for someone who doesn't have the money to pay for their medication. Then another alternative is to start the medication privately, so pay the cost of the reviews and the cost of the medication itself. And when the optimal dose has been established, there aren't significant side effects, we would go back to the GP and say, could we agree to share care here? Where we say, this is what happened. And I can guarantee we are very thorough with our records. This is what happened. This patient has come through for a diagnosis. We established an optimal dose. Can you prescribe on the NHS? We will be responsible to review. That's the quickest route to accessing ADHD medication, but not all GPs would agree to that shared care. I must say that the majority, especially the ones who perhaps they're used to our reports and to working with us, they're okay. But then if a decision not to go for shared care agreements is made at an ICB level or a practice level, the GP will have no choice than pulling away, leaving a lot of patients without support. Another thing that happens as well with the right to choose. So it's not just with clinic like us, but you may have patients who go for an assessment through the right to choose. Usually the waiting times are much shorter than the NHS, so it would be between 6 and 12 months. And then, they are referred back to their GP for medication, at which point the GP says, we don't do that. We have nowhere to refer you. Or this service, the service we could refer you on does not accept this assessment that you've just done. So that feels incredibly frustrating for people. Sometimes the private care, the right to choose provider will start titration and then go back to the GP and say, can you please prescribe on the NHS? And even there may be cases where this pathways are not integrated, which means, again, a lot of trouble for the patients. Where we advocate, we mediate. I personally get on the phone with GP practices and try to understand if there is anything that we can do to make the situation better. But it is so diverse around the country. So it's not like one area in the same county is funded in a certain way, another area in the same county may be funded in a different way, and they therefore, act in a different way.
So you talked a little bit about paying attention to feedback. Are there any other metrics that you focus on in terms of the business, caseloads, client experience that you're particularly interested in as a business owner?
Yes, well, I am personally interested in clients' experiences. So their personal story, I try to follow up with them to see if the diagnosis actually has changed, or the outcome, I should say, of the assessment has changed. Anything in their life, if there is anything else that we can do. In terms of metrics, we are at that point, we have this, I personally have this little privilege of training clinicians. So if there is a bit more demand, I can always pull from these clinicians and say that the ones that I supervise, perhaps, and I would say, would you like to join as an associate, or would you help us out? Because in this moment we have more assessments, so that we keep those waiting times really, really short. And usually we are able to see someone within 4 weeks from when they first come to us. We don't have the same demands that the NHS faces. Let me say it loud and clear. So we don't see thousands of patients. So we see a handful of patients during, a quieter month, and then a busier month. It might be a dozen, but it's still very, very manageable compared to the volumes that the public healthcare system faces.
So what's next for you in the Spectrum Clinic, perhaps over the next year? Are you looking to go in any particular direction with your work?
Well, we are exploring some partnerships with other clinics just to try and offer a 360 service around our patients. So expand on the coaching offer, for example, the medication offer. We are going as we speak through. We're working on the CQC registration, and we will be considering right to choose, but it very, very reluctantly. Very reluctantly. It depends on if we feel that the quality of our work is we can sustain that, basically. If we cannot sustain that, it will not be my choice. So
I presume that's going down that line is really to kind of help with the supply-demand mismatch. But have you got any other ideas about how this can be solved more nationally in terms of the demand for the assessments versus the number of people that can deliver them?
Yes, I do. I don't know if my view is very realistic or many people will want to invest in that, but I see healthcare as community care. I imagine centers where you can walk in and you get helped. There needs to be training. The staff needs to be retrained, and a revision of what the NHS has been doing in the last few years, because I tell you, in 5 years in CAMS we had restructuring every year, and those who leave are the most senior people in the service. Then end up in private practice where there is all the offer is. So yeah, definitely training, understanding is the cultural shift that needs to happen from. You need to imagine that in services like CAMS especially, the pressure is very high. The demands are really high. And staff is always one step away from burning out. So that is the situation. They are in a crisis. And then you have on the other side these patients who perhaps are also in a crisis and they cannot be seen. So when they eventually see you for the first time, it's not necessarily a pleasant meeting, because the focus will be on what you did wrong, why you didn't see me, why was the referral rejected, and so on. All those conversations that could be held somewhere else very early on. And also, do people need a diagnosis to be supported, to be offered the therapy? I'm not thinking specifically about medication, because, they are licensed for specific conditions. But to make environmental adjustments, so to have someone like me going into school and say, okay, what can we do to help this 15-year-old, this 14-year-old, or meeting with parents, what's not working, that can happen early on. And unfortunately, people want or seek out a diagnosis because they cannot access. It's not just to have a label. Many times it's to understand themselves, because it brings some kind of relief that they've not been making it up, basically. That is a genuine experience and they want that kind of validation. But also is that the majority of them is because they need to access support, and they're told, well, we can only offer this if you have a diagnosis. We can only do this if you have a disability, and so on. So let's try and reverse the thing. Let's offer the support first. Let's train clinicians to be more compassionate. Ideally, more people working, because it goes down to funding and to the number of people working in any given service. So, yeah, does it sound utopic as a vision? Perhaps a bit.
On that note, Antonietta, thank you so much for your time this afternoon, for the very insightful, honest conversation. Not just that, but also for the work you're doing in challenging assumptions and improving how neurodevelopmental conditions are understood. It's been a real pleasure having you on the show. Thank you so much.
Thank you, Andrew.